with the North Central Regional Center for Rural Development, and we're pleased to present one of our CAPE webinars. The CAPE is the Community Assessment and Education to Promote Behavioral Health Planning and Evaluation. It's sponsored by the Substance Abuse and Mental Health Services Administration and the USDA. And today we've got Dan Warner. Dr. Dan Warner is a clinical psychologist and the executive director of the Community Data Roundtable, and talking about some of the things that they're doing there in Pennsylvania. This is a Pennsylvania-focused effort. Thanks a lot, Dan. We'll just turn it over to you.
Okay, well, thank you. Let me see here. I think I just tap right there. So what we're going to do today is I'm basically just going to introduce the project that we're working on at Community Data Roundtable. To do this, I'm going to first explain how behavioral health services are typically prescribed in Pennsylvania. And when I say behavioral health services, I'm really talking about the Medicaid-funded services primarily for children. We're going to talk mostly about children today, and mostly Medicaid-funded. We're going to talk about some of the problems that have come up historically in trying to use diagnostic related groupings to do behavioral health service matching. And then sort of the solution that our organization is posing to try to overcome the barriers of the DRGs. And then we're going to talk about some of the ways we're really trying to use this data. We're really an applied group. We are funded by organizations that want something out of the data we're doing. It's not just a pure research organization. And in fact, that's something that we love, is that if we have our data available, if researchers want to look at it and do something with it on a more academic side, that would be great. But we are very focused on practical questions, in particular about helping inform medical necessity criteria. We can talk, and we'll talk more about that in a little bit. And then this last piece was really supposed to be talked about by my partner in crime, Jesse Troy, who you'll see a picture of in a second, and the particular analytic methods that we're looking to use. So I'm going to, I can give the basic overview of why we're looking to use latent class analysis and how we're hoping to work with that. But real wonky questions, I will be more than happy to connect you with Jesse Troy afterwards if you contact me. So let's move forward. Community Data Roundtable is a nonprofit corporation supporting data-driven decision-making in Pennsylvania's public mental health system. Our mission is to bring together stakeholders from Pennsylvania's community behavioral health system to implement a collaboratively beneficial outcomes monitoring system. And our conviction is, when done right, an outcome system brings clinical and economic efficiencies to benefit all parties. Just pause right here that so we've got a very robust and large community mental health system in Pennsylvania, and one that I always encourage us to be proud of. We have it's about $1 billion just for children. There are wraparound services, which I think many people will be familiar with, in which they can do very individualized plans to help children who are at risk of losing school or home placement. And that can be that service can range from a behavioral tech who's working with the child and family one-on-one, upwards of 40 hours a week when things are very severe, or an in-home family therapist. We have many evidence-based programs that are funded throughout the state, from high-fidelity wraparound, functional family therapy, multi-systemic therapy, incredible years, parent-child interaction therapy, multimodal foster care. So I feel our advocates and our policy people and our businessmen, the providers, we've done a very good job of getting the stuff out there. But it is really unmanaged at a data level right now, except for very basic questions of how many, are the services being provided, how many people are being moved through. But we don't really know the outcomes on this stuff. We don't really know, is the matching going well? So that's, and the reason for that is, even though if you were to talk to almost anyone in the field, they would say, yes, we should have this. But there's a lot of fear about how data would be used. Every group has their own concerns about that. And so the point of the roundtable was to set up what I like to call sort of a data Geneva, and a space where you can trust that the data that's coming through is clean and is unbiased, and that it will be reviewed in a public way. I should be clear on public is not just it still will be, because data can also be abused, there are still parameters of what public means. We limit it to competent and professional members and people who are joining up with the group. But once in, it is an open process to facilitate what data should do, which is to really create a collaboratively, mutually beneficial system for all parties. And so that's what we're working on. Oops. And yeah, we recently won a Robert Wood Johnson Voices of Quality Award, which was kind of nice. And then I sat in on the webinar on that. And Robert Wood Johnson seems to be really sponsoring the same kind of model that's now being used actually in a lot of different places. Different groups are coming up and saying, you know, we need data, but it's expensive. And everyone would like it, but no one can do it. So there's these models that are coming forward of bringing people together to everyone puts in a little bit to get something that's helpful for everyone. So that was kind of cool. All right. The stakeholders that we, when I talk about stakeholders, I'm talking about 4 distinct groups. And here's where my arrow is helpful. Okay. First, of course, is the consumers and advocates. I've personally benefited very much from help when I've had my own family members with mental illness, and when I've also just needed to do work in mental health, working with NAMI. So NAMI's been very involved with us. I'm just a really big fan of the kind of advocacy they do. I understand that in other states they're actually a very small group, but in our state they're pretty organized. They've got a corporate office and they hold a lot of events, and they are very essential in representing the voice of the people who are actually the most important when we're talking about healthcare, which is the actual clients and consumers. We also have MHA, the Mental Health Association, which is more of a direct consumer group, typically more oriented towards adult issues, but they have been involved with us on child issues. They're involved with us as well. Then, of course, they're the providers. These are the people that do the work. This is the group that I am. I also have a job where I am a clinical director for a multimodal mental health system where we do everything from outpatient work, psychiatric, in-home, case management. And so I know the day-to-day work of mental health. And the point is, very often, data is a nuisance when you're really doing the work. And I was actually even trained. I'm a clinical psychologist, and I was trained in a very traditional conservative program that was believed that there's no ability to measure anything in the mind. It's all going to be done with language and interactions. And I don't believe that, but I am sympathetic to that argument, and I had to pass my comprehensive exam, so I argued that position very, very well. But I now feel that I'm in a position to help really talk with providers about why data is helpful. And this also is why I've gone with a communimetrics tool, which we will talk about shortly, because communimetrics tools are very friendly for clinicians. They are really clinical tools that happen to collect data. And when you get that, providers really jump on because they're like, well, if this is going to help me do my job, then I'm happy to do it. I don't need to worry. It's not some extra form I need to fill out. So that's another big group that's important to us. Then, of course, state and county government. These are Medicaid dollars. These are government dollars. The government is involved in various ways. And Pennsylvania has its own unique quirks about how things get done. So if people want to know more about that, we can talk about that. And one of the unique quirks is that all the Medicaid dollars are funneled through underwriters, managed care entities. So basically the county government, these people right here, get the dollars, and then they give them to this group. The state oversees it, but this group actually distributes it. So this payer is a very essential part of the equation for anything to be moving forward, and getting this alliance amongst the 4 is our goal. The leadership for this group is first me. I'm Dan Warner. I'm the Executive Clinical Director of Knowlton Diagnostic, which is the multimodal mental health practice I was talking about. We have about 100 clinicians, and we stretch across Pennsylvania, mostly rural. We're a rural mental health provider. And most of my experience, my training was in Pittsburgh. So I have and I live in Pittsburgh, so I have an urban background, but my work has been primarily in rural areas. And I've really enjoyed that. And then I've also got a background just to notice that I'm a member of the Pennsylvania Psychological Association. I'm the chair of the Insurance and Managed Care Committee and the Medicaid Subcommittee, and I've been very involved in issues of managed care and practice for through graduate school, not all of graduate school, but through much of graduate school and today. So this is something that's interested me for a long time. And then next is Jesse Troy. He's our Chief Data Officer. He has a background in public health. He actually graduated from Pitt as an epidemiologist. And his background is typically in cancer research. But I should say that Jesse is actually an old buddy of mine. Here, my next picture. Here's us doing our first science project together. As you can see, I've accentuated that I used to have hair. And I assure you this is not quite the way I look anymore. But back in high school, it's our sophomore year, we did a science fair project on tropical fish of the Amazon. And we then, grew up. He went to one college, I went to another college. We actually didn't talk for about 10 years, but then he came back to Pittsburgh to go to Pitt for graduate school, and we hooked back up. And through that process, I started talking about the problems we were having in behavioral health about not having a data understanding of the whole field. And Jesse was saying, well, this is the kind of stuff I look at as an epidemiologist. And that's where the Community Data Roundtable was born. So, and I should say you're welcome to, I think, Scott, if I'm correct, they're welcome to ask questions at any time. I'm happy to pause. I don't need to keep going straight. You can just type in the chat box. Okay,
Absolutely.
yeah.
Yeah.
So if you just type in the chat box and I'll address it. So feel free, but I will just keep moving. So how a child is prescribed wraparound treatment in Pennsylvania. So I already described wraparound. I think most states have wraparound of some kind nowadays. Different funding streams for that. I know that in some states it comes in mostly through children and youth dollars, but in Pennsylvania it comes in through Medicaid dollars. And then I know in some states it's very limited, but in our state it's actually, we have something called the Medicaid loophole, which is that any child in Pennsylvania who has a serious mental illness can qualify for Medicaid. So you could be a Rothschild or a Gates kid or whatever. You could be rich, my point is, and you could still qualify for wraparound services if you have a serious mental illness, which is really great. I mean, it's had well, of course, I say it's really great. We don't have great data, and this is where I come in, but I can speak anecdotally to the impact that I've seen that's positive thanks to these services. And it is not uncommon to see families with seriously mentally ill children move to Pennsylvania for the services. So here's how the service gets actually prescribed. So BHRS is what we call it, by the way. So wraparound is a general term. We actually have something called behavioral health rehabilitation services, BHRS. They are primarily prescribed by a licensed clinical psychologist. And the idea was, and you can see it in the regulations as they were written up, that you would have this psychologist who would come in and he would diagnose all the kids, and then he would just connect them to the right treatment. And because that's really the way things work in medicine, and the lawyers who wrote the regulations said, and it makes perfect sense, this would also work in mental health because it's just another sector of health. Well, the fact is, if you work in mental health, you know that it's really not that simple. It's not as simple as DX is, of course, diagnosis and TX is treatment. Because you can have three different similar diagnoses, but because of other interactions, like a comorbidity of some kind, ADHD with a pervasive developmental disorder or an autism, ADHD with a mood disorder, then the family is so key in mental health, from an organized family to a disorganized family to one with significant traumas in it. Then, of course, you've got your learning problems that can impact these things. These things do not necessarily correlate with learning problems. You can have gifted children with ADHD or any mental health situation, or they could be in some sort of alternative schooling, which is going to be very different. Alternative schooling is a education funded thing in Pennsylvania, where if a kid is not succeeding in regular school, they're supposed to have these special schools that are well geared to deal with behavior problems that are not mental health problems. So if you have mental health problems that are impacting your schooling, you either get wraparound or partial hospitalization for children. But if you are just, what quote unquote just a behavior problem, it's not mental health driven, then you have these things called alternative schools. And then you've got, of course, the community level of things and the psychosocial. So it becomes very difficult. And these are not just, and if you, as you know, and in fact, let me move on to my next slide. What we're really talking about is an ecological or a structural model, which I believe is fundamental to doing mental health work, especially community mental health work. It is very rare you have people whose functioning is fine, whose risk levels are fine, and they really just have some mental health, some depression or anxiety that they need to work on in a therapeutic way, be it a pill or be it psychotherapy. More often than that, though, the intervention has to look at the habitus, which is a language you hear a lot. This model, I think, is pretty famous for people working in our field. Bronfenbrenner's, sorry. Ecological model of development where a child is in a microsystem, which is in a larger mesosystem and exosystem. And these things are all impacting the ability of the child to develop appropriately. So we need a tool. Well, before a tool, we need a mindset that thinks this way when we are making prescription and treatment decisions in mental health. And this is actually already understood in the wraparound philosophy. I don't know how many. So there's a sort of a famous book. It's not really a book. It's more an extended essay by a woman named Jane Nitzer. Oh God, what's it called? Lost Children. I can't remember exactly what it's called right now. If anyone remembers. I just looked down here. I'm sorry. I thought SSI also covered those with mental illness, not for wraparound in our state. So SSI can get you patient services covered, but would not get you wraparound. So that's not a big deal. If you have SSI, you just use the loophole and you get on wraparound. So I hope that answered your question. If you want more clarification on that, just write in another question. So the wraparound logic understood that there are psychosocial difficulties that have to be taken into account. So the idea was that the psychologist would diagnose and then refer appropriately based on the logic. And what I have here is this is the provider, this is the family, this is the community, this is school, this is juvenile justice, this is school, and that the diagnosis would pass through this stuff and you'd get a really nice comprehensive treatment. Here we have this child with RAD, got mobile therapy at 3 hours a week, youth group, and a community integration program. And then this child gets diagnosed with RAD, but goes through has a different situation psychosocially. So they're just going to get weekly outpatient family therapy with a NAMI integration and a school counselor. So that's the way it should work, and I would say it does work. However, this is a very complicated clinical process that is not necessarily well informed by evidence. Um, there's no standing evidence base to inform this complicated clinical decision-making process, nor is an established clinical tool which all psychologists use to inform their decisions. And if you look at my image there, it's a blind doctor writing a prescription. And, this is actually the kind of question CAPE could probably answer better, but I can say that there is a general sense in our state that basically psychologists are just referring to the services that bring them in to do an evaluation. I've heard the language sometimes uses their hired guns, or they're more treatment justifiers instead of really building a treatment plan. What they're doing is providers go out and get as many people as they can that would generally match what they do. Then they bring in their psychologist who rubber stamps and says, yes, you've got a diagnosis. Come on in at the highest amount of hours that I can, realistically prescribe for you. And so I think that stereotype is overwrought, but it's also not. First of all, we have no data to say it's not true. So that's one thing. And second thing, that there's also something to that. As a provider, there have definitely been situations and definitely provider groups that I've worked with that have really had the philosophy of, any kid who's got any kind of problems has a mental health problem. Okay, this is not a factual statement, but that's a statement some groups will hold, that, hey, if this kid's acting out, it's because of something mental health, and the best solution is going to be behavioral techs at 30 hours a week. And with that pressure from your boss and that pressure from the family and that pressure from various places, and without an evidence base of some kind to resort to in making a decision, you start to see really informal relationships driving service selection instead of data and good clinical decision making. And I think this hurts kids. And more than, I mean, I guess I'll have, hopefully have data that might show that, but I definitely feel that I can speak to kids that I have been too long in the system and who are not benefiting from it, and they're not able to move forward in their recovery in effective ways. And I also know that that NAMI and MHA, two consumer advocacy groups, have been very emphatically agreeing with me on that, and that's why they're involved in our project, because we understand that the treatment doesn't more treatment is not always the solution, and what we need is the right treatment at the right time, and that's what we're really trying to get to with CDR. So we had to find a tool that could do this. And I'm not going to go through our whole odyssey of the different things we looked at. We eventually settled on something that I'm a really big fan of right now. It's called communimetrics. People might know it on this phone call as the CANS because it's become very popular. That is the tool we're using, the child and adolescent needs and strengths. But communimetrics is its science, and I want to talk about that because I think that's the most informative thing for understanding why we're using this tool and how it helps. So the Child and Adolescent Needs and Strengths Assessment, it was developed by a guy named John Lyons, and he developed it because they were trying to reduce the amount of beds in Illinois' residential placement. Over the 80s and 90s, residential placements really grew throughout our country. And there was a general consensus amongst clinicians, policymakers, that we had too many beds. We need to really figure out who needs to be in residential placement, who doesn't. And John Lyons is actually on the editorial board of the big journal in residential treatment for children. I forget the exact name of the journal right now. And this was a big question for him. He had done research originally that really helped separate, because some people think residential placement doesn't do anything. It's just boarding school for the poor. While some people think it's the answer for everything, typically people who own a residential placement. So what he did is he did some data with a lot of different tools and helped to identify that there are some kids who benefit from residential placement and some kids that don't. And the kids that do have a certain profile, and that's different from the kids who don't. It's an obvious statement, but once again, in this field, there is money before there is data and understanding. And so he was able to start differentiating these kids. This had a very big policy implication because before they got John Lyons involved in Illinois, they were just having committees within the residential facilities decide who should go home and who should stay. Well, if you do that, think what's going to happen. The committee within the RTF looks at their stack of charts and says, well, which kid are we not helping? And they're not going to go with the easy kid because the easy kid is nice. They go with the kids that are really too much for them. The really aggressive, really dangerous kids. They say, we're not helping. Let's get rid of this kid. So there was one group that did, and that kid went home, killed his grandparents. He actually didn't go home. He went to live with his grandparents. He killed his grandparents, and I think he killed himself. I don't remember. But it was a major disaster, and it put on hold this bed reduction project in Illinois. So he was brought in with the CANs, which we'll talk about in a second, and it was much more successful because it gave a structured, clinically rational reasoning for differentiating those kids who should stay in residential placement and those kids that should go home. Another cool thing about the CANs is it's public domain. It is built on the logic of Unix and in all these other kinds of open source ideas out there. So he's got the idea, right? In his book, he's telling you how to do it. It's a do-it-yourself. And then you can go up there and start building your own outcome system for your particular, be it practice, county, state system, whatever it would be. Now, I have a little asterisk there on the free because doing all that stuff yourself costs a lot of money. But in principle, everyone can use the CANs, and it's available at this website right there. It's now used all over the place, and I can answer any questions that people have about that. It's actually being used around the world now. But that leads to its own complexities because, as I said, it's do it yourself. So this group does it a little here, and that group does it a little there, and so now we have the Tower of Babel emerging. And I think this is just something the CANS community is dealing with moving forward, but it is a complexity. And as I said, it's free because you have to do a lot of your own work. You got to design your own version. You got to analyze the data. You got to find your own norms. And I forgot to say on my list here, you've got to find your own database to hold all this information. And obviously, all of those things become quite costly. So here's the cans that my organization's designed for this project right now in Pennsylvania. Um, but I won't go into details on that. I can do that offline. But I want to talk about the three basic ideas behind communimetrics because it is different from a typical psychometric tool. When you think about psychometrics, you're typically thinking about stuff going on inside people and very objective measures, very precise measurement designed for laboratory measures. We don't do that in community mental health. We're measuring people in the field, and we're measuring people in their world. So we need a very different kind of measure. The basic logic of communimetrics is that any given work environment has a finite set of basic action pathways, things that get done. And so what Lyons spent a long time on while developing the cans is getting the fundamental things that get done in community mental health. And I think he did an excellent job on that. And I think the fact that this tool is being used so widely speaks to the fact that no matter if you are in Singapore, where they're using it, in Canada, in Ecuador, or in Johnstown, Pennsylvania, there is a common set of things that get done when you're doing community behavioral health. And those are your basic action pathways. And those can be identified by those who live and work in the environment. So you go to the people who work there, who get worked on, i.e. the consumers and the clients, and they say, what are the things that get done? And he's already done most of this work, or at least the basic work for your basic cans to lay that out. And then once they've been identified, they can be put in a list. And that's basically what the cans is. It is a fancy checklist. And there are some people who guffaw at this because they say, oh, psychometrics and behavioral measurement is so much more complicated than a checklist. And there's definitely something to that. I would never want the MMPI or the kind of work that an MMPI does to be just a checklist. But this actually, for what we're doing with evaluation, it's actually perfect that it be a checklist. I'm not sure if people know a very good book by Atul Gawande, The Checklist Manifesto. I highly recommend it. It's just a wonderful, well-written account of the power of organizing your thinking in today's complicated works. Do I not have that? Okay, so just to say that the argument that Gawande makes in this book is that today's professional tasks are just too complicated to wing it. It helps to have some list to make sure that you can monitor your own cognitive work. And this is, of course, not sexy. Professionals, we like to think that we just have all this presence in our frontal lobe and we're bringing it out, and we don't need some silly piece of paper to keep us oriented. But boy, does he make some wonderful arguments and presentations of the opposite in this work. And I can also say that I have improved as a clinician greatly by disciplining myself to the cans. So the cans has repeatedly shown itself to be as reliable as similarly used psychometric tools. I'm going to speak to that more in a second. But let me speak right now about the action levels, because I think this is very important. So the cans is not, a typical checklist is just 0 and 1. It's just a binary system. You've done it or not. Check on, check off. The cans has actually added a little bit of more nuance to this, which gives us more mathematical possibilities, as well as clinical possibilities, which has been very helpful. Instead of every item just being on or off, there's 4 different levels. A 0 is off. There's no action need. Let's say depression of 0. There's no depression here. No action is necessary. 1 is, though, a really helpful category. This is we're watching. So we're not seeing depression. We're not going to need to work on depression, but this client has had depression in the past, and I'm going to let other people know that I'm watching it. I'm going to remind myself that I'm watching it. I'm going to let the client know, hey, I know you're feeling good now, you're getting out, but let's just keep an eye on this. But it's not actionable yet. We move to action with a 2. This client has depression. We need to address it. We need to implement the action pathway on depression, which is typically a psychiatric consultation. And if it's just depression, outpatient therapy. That is the typical action pathway for a clear depression task. 3 is we've got a serious problem, immediate or intensive action. This is a client that needs to be hospitalized due to the depression because they're actively suicidal, or it's just they're not able to leave their house. It's just completely hamstrung them. So these are the levels that we're looking at in CANS that everything's getting measured on. Now, I want to help differentiate communimetric from psychometric because that's going to help everyone here understand the kind of analysis we're doing and what we're really measuring. So communimetric, as I said, is measuring communication in a system. What is getting done and what needs to get done. When I evaluate a client and score a CANS, I am saying these things need to get done so that the next clinician can pick up the CANS and say, oh, this is what needs to be done. Psychometric tools do not work that way, right? They are measuring things to help me figure out what needs to be done. So it's really at a very different level of measurement. So this provides a vision of the client in a biopsychosocial sphere. You will see does something need to be done with their schooling? Does something need to be done in regards to juvenile justice? Does something need to be done with their family? While a psychometric tool is measuring invisible entities within a person. How depressed are they? Is there trauma in here? Is this ADHD? So any of that kind of diagnostic stuff, the CANS is worthless for that. You need to know how to diagnose. You need to know the diagnosis yourself. This is one of the reasons we like having psychologists fill out the CANS, because they bring that with them to the table, and then they have an easier time scoring a CANS. In other areas where they don't have credible mental health professionals filling out the CANS, that part of the CANS is filled out by going into a chart and just pulling that information. So once again, psychometrics measuring what's inside of a person to help do diagnosing, while the communimetric, you've got to do that yourself. Now you're able to measure the person within the larger habitus. So the communimetric tools, interestingly, clinicians love, and I don't know, I don't know really who's in the audience today. I don't know if you're researchers or not, but if you've ever tried to get a clinician to participate in your research, they don't want to. It gets in their way. And they have, why do I have to fill out this? And do I really need to do that? And is this box need to be filled in? The difference with a communimetric tool like the CANS is clinicians instantly flock to it. You have very little problem with fidelity in the marking because it's helping them do their job well. But because of the fact that it's not as structured as a good psychometric tool, very often I have found researchers are very skeptical of communimetric tools at first. Definitely with time they become convinced and they start to understand it's measuring something different, and it's measuring that different thing very well. But the fact that it's so unstructured in its approach at first will put some researchers off. Once again, the CANS is not helpful, or communimetric tools, the CANS are not helpful for diagnosing, and this is exactly what psychometric tools are often designed to do, to help clarify what's going on for you inside. And then the communimetric tool facilitates communication across the team, while the understanding for a psychometric tool is in the expertise of whoever's interpreting the results. So the CANS, when you review a CANS with a client, they don't need any particular training. And also I share CANS with bachelor's level people or paraprofessionals like peers. There's an adult version of the CANS called the ANSA, which we also have a very large project with. And the peers, who many of them will not even have a high school degree, they can understand the CANS or the ANSA just fine, while they will have a very difficult, an almost impossible time with anything like a BASC or an MMPI would just be completely out of their depth. You need an expert to bring that knowledge down from the mountain. All right, so now that we've explained the communimetric tool, I need to explain how it's going to help us do decision making. And this is where algorithms become very important. Once again, my ultimate goal is to help clinicians do service selection. I showed that you can't just use a diagnosis to connect people to the right treatment. You need something that looks psychosocially. And the CANS, I've argued, does that by measuring mental health, measuring someone in their functioning, measuring someone's risk, measuring someone in their family and their school. All these kinds of things are accounted for. Well, then what? How do we make this the selection from there? And here is the basic model. What the CANS does is it turns a person, here's my client, and it turns them into numbers, right? So here, this client has a mood problem at the level of 3. If you remember, I said 3 is a major problem. Autism, none at all. Family, a little. We're watching it. There's some strengths. The CANS also measures strengths. I haven't talked about that, but that's also in there. There's some strengths there, and a significant trauma has occurred. Then you've got three different programs. I'm not going to tell you what they are. This one is for, we can also, so what we do is we go to the service descriptions of these programs, and we say here the mood problem. This is a program for clients who have mood of 1 or higher. So you can either be watching a mood problem or it's significant. This is a program for kids that don't have autism. They can have a little bit of family problems, but that's not really what they do. They need to have a little bit of strengths. They can't have no strengths at all, and they can take trauma. They can deal with any level of trauma. This is a program for kids who only have a little bit of mood problems, and really it's designed for people who have autism. And here as well, this is a program for kids that we really don't want any mood problems here at all, but any kind of autism we will work with. So what you can see is that we've laid out these numbers for the programs, and we've laid out the numbers for the client, and then it becomes a matching process that connects the client to the right program. And that's what we're setting up. That is, we've already started this actually. We have not yet used computer algorithms. Those are going to go live on May 5th. But we now have care managers at the insurance company. When an eval is submitted, they utilize a paper tool to go through the CANs, compare it to the evaluation, and then make sure that the treatment selected was appropriate. So it's not as rigorous as will be possible when we have much, computers can do a lot more processing than a person can. But this is already in place at a very minimal level. Are there any questions on that? So there are 2 levels to the algorithms. I think this will be important to know. For those people who've ever worked in behavioral health, you know that, I have a question here. Let me see. How do I approach local mental health service providers to see if they're using their screening tools for individual screening or Also, how do I ask if they are happy with their current data quality and evaluation tools? Well, this is actually the question that I, on a regular basis, ask providers. Oh, by the way, I think someone turned off their mute. Oh, okay, there we go. But let me see. I don't. As far as how, I don't know. I mean, what I've been I just go out and do it. I mean, I might just be very brazen, but I've been going to local conventions and local conferences and putting out the information, and I find that administrators in provider groups right now are very interested in data. They want to know they're doing a good job, and they want to manage things, especially with. And I'm not going to talk about it during this presentation very much, but there's been a big move on compliance where you've got auditors who come in and they look at the paperwork of the frontline clinician and compare it to the evaluation and the treatment plan, and then you've got to pay money back if things don't line up. That is something that is very much improved through data-driven systems. And these provider owners and provider managers know this, and that's how I've been engaging them with the question. Typically what you will see for the most part, except for some systems that are more robust, what you have at best right now is clinicians filling out a form and putting it in the chart. And I have engaged a lot of providers in the fact that they find that a pain in the tuchus, that it's obnoxious and they're doing it just because they're told to do it and no one feels they're getting anything out of it. I'm actually currently working with providers who are filling out CANs in that way. They're filling out CANs because they were mandated by the managed care entity they're working with, but they didn't know that there's any data in them for them at all. They didn't know it could even be helpful. No one told them this is a helpful clinical tool. So that would just be it. Is that the thing about the CANs is I feel I'm always bringing a solution to really pretty much any stakeholder, but definitely providers. And when they start to hear what the CANs can do for them, they get very. So far, I've had a lot of excitement in it. So I'll move forward. If that didn't answer your question, please write some more. So if you work in mental health, you know that, especially community behavioral health, regulations are God. They are directly from Moses, from the mountain. And there are a lot of reasons for that. But basically, it helps clarify because a provider's job is to get their service to as many people as possible and get reimbursement for that. And a payer's side, be it managed care or government, is to actually regulate that payment and to really pay as little as they can per member per month so that they can generate their own profit. And so the only thing in existence right now that helps mediate who should and shouldn't are the regulations written in code. Because, and this is true, I find this is not just true in Pennsylvania. I'm obviously most informed about the Pennsylvania system, but I talk to people across the country, and this is true that there is usually some process. I go apply for I apply for a service. If it gets denied, there is some grievance process I can go to that will eventually end up at a judge. It might just be a fair hearings judge, but some government official whose job is to make legal proclamations, and that person will look at the regulation about who gets a given service, and we'll look at that client and we'll say, hey, if this client matches a service, this client gets this service. So we needed to start there. We couldn't just come in with data that says, oh, these regulations were wrong. They were allowing people with this particular factor to get that particular service, which is really silly. It should be this other way around. You should just listen to our data because our data is going to fall on deaf ears. What we needed to do was to start with the regulations, get an understanding of that, and then modify our understanding of service selection as more data comes in about outcomes. Because that's one of the problems with regulations, right? They just say who can get access to a service. They don't have any claim about outcomes from a given service or why a certain service selection is going to lead to outcomes. It was based off of consensus of professionals that were around when the laws were made. So our algorithms start with the service descriptions and regulations. If you were to remember here, all of this profile came from what the program in their service description said they do. Same thing with this one. This program said they do this, and this program said they that. I just translated it into CAN's language, communimetrics language. And that's going to be that is the first wave of how we make a profile. So we give a CANs to a kid, and then we set them up with the program that is designed in its service description to match what that client has. However, then comes the mathematical analysis of outcomes and latent classes. We'll talk about those in a second to inform decisions within the bounds of the regulations. I've got this image here from Catch 22, which is, I think, a very helpful book for those of us who deal in bureaucratic areas. There's a wonderful scene where someone goes to Major and says, because he's been told he's been dead. Some paperwork got filed that said he's dead, and he said, "But obviously I'm not dead." To which Major responds, "Yes, you are. I signed the paperwork on that yesterday." And that's sometimes what it feels like when you're referring people to services, is that this service is not supposed to be for me. Well, it's what you match, it's what you got. So the blending of our math with the regulations is something that starts moving forward. As we start getting a better understanding of the profiles of kids that match with various forms of treatment, various action pathways, we can start making even better decisions within the bounds of regulations. We will never be able to trump regulations. The best I could hope for is that the government would say, well, in light of this data, we will now shift these laws. Although I'm not in any way encouraging that, because whenever laws shift, everything is on the table, and I don't like change when it comes to that. But the truth is, the regulations are typically not putting people into unhealthy directions. What they're doing is they're just not nuanced enough. And data is really adding a lot of nuance to the prescription. Now, just to close off, latent class analysis is important for the kind of analysis we're doing, because we've got a lot of data points in a CANS. Our CANS has so it's got like 50 overall, and then you've got these module topics that come down into the mid-70s of items. And what is it? What are these profiles underneath that do get better in certain programs versus ones that don't? So latent class analysis identifies unobserved groupings in large, complicated data sets where relationships are hard to see in traditional visual methods. What it sets up the whole CANs and gets set up as a bunch of probabilistic statements is what it comes down to identify data groupings and differentiating them from those which occur by chance. So what is it that is, we keep on seeing this particular cluster of CANs items, which is seems to improve when it goes through this particular program. Is that just due to chance, or is that due to some clinical action in that program? And LCA helps us see that the probabilistic differences between a by chance grouping and a real grouping, and then helps us say, well, maybe there is a CANS profile here of the kind of kid that does well in that kind of group. And once again, this is a bit of a repetition of what I said before, but I'm thinking it'd be clearer now. We have a two-step process. One, we identify the underlying CANS profiles, i.e. the latent classes, and then we analyze the relationship between these profiles with outcomes and prescription patterns. And then comes the whole roundtable process. So as I said, our members involve consumers, providers, payers, and government. And then as the data comes in, there are various decisions that need to be made. Identification of community needs. There's been one of the groups that we're working with right now has found they really need an intensive in-home service for youth with externalizing disorders, oppositional and mood disorder, and they don't have that. What they have is this kind of after-school program, but the evidence base is that these programs like MST or FFT are better for that, and we've been able to we're starting to be able to see that better in the data. They have a larger group of this youth than they were aware. Then there's also just choosing questions to ask of the data, which is a very political process. Some groups sometimes don't want to know certain things, and some groups do. And so that's my job, is to help find ways that we ask the things that everyone needs asked, and that people feel that their questions are being heard, and those kinds of things. Naming identified latent classes has become a big issue, because when we do identify these profiles, what is that profile exactly? Is that the externalizing ADHD youth school problem? That's or is this something else? And of course, there's politics to all of these things. As you start to name mathematical models, people's feelings get involved. So that's a lot of the things we work on. And then charting new tasks based on gaps and opportunities presented in the data. Fundamentally, this is a market-based approach to solving a problem. These are businesses that run these community mental health services, and they take a lot of risk, and they do a lot of good when they come out. And so that is why they cling to regulations, because they've taken risks based on known factors. And if someone comes in and decides to kill their program based on something random, that's not good for anyone. So what I try to do in the roundtable is really give the providers access to what's going on. It's an opportunity to look at what's going on in the community with the payers. And then they can collaboratively say, hey, you know what? We need a program that serves this youth. And we know through looking at our data that there's so many youth over a year that have this problem. And so the provider can say, okay, I'm going to build a program that matches those specifications at this rate and provide the service. So this really should help providers be able to act within an arena of less uncertainty, more controlled risk, which should benefit everyone. And these are just some of the biggest things already that I found I'm working on with the roundtable. I guess I should also add that we do a lot of consultation on how to help your compliance problems, because these tools are very helpful for that. And I think, oh, right, some exciting preliminary findings just to share. And once again, I don't know who's on this in the audience, but this to us has been really cool stuff. We're starting to identify latent classes of seriously emotionally disturbed and autistic spectrum disorder youth, which correspond to prescribed hours of behavioral technician work. This assists in the rational prescribing of such behavior technicians for working with various populations. To put that in a clearer language, one of the big things going on across the country right now is getting behavioral techs to autistic youth, but there's no standards to identify how many hours of behavioral tech. There is this general research put out by Catherine Lord, who's really the empress of autism in the world nowadays, saying that between 25 to 40 hours a week is what she thinks is right. Well, that's actually a very wide swath, and she didn't really base that on large data sets. So we're starting to find numbers that are actually broader than that because we're measuring autism on different functioning levels. So this is actually pretty exciting, and we think could impact things across the country. And we are also increasingly linking clients who meet profiles for evidence-based programs with appropriate programs earlier in their treatment odyssey. Because the rule is you go to the first service you happen to end up at. And through this process now, people don't necessarily just go to the service they end up at. They go to the service that they match. And for a large amount of kids, we're able to get them to evidence-based treatments. And I'm a personal believer that that's always a good thing. Well, thank you. So I am done, and I am open for questions.
Oh, great, Dan. That's a fascinating and rapid overview of a lot that is going on in your life, and it's really interesting set of activities. One, so let me just. I'm assuming that this sheet here is your basic data
Well, that's
that
actually, you know what that
you're
is? That's a
dealing with,
basic
right?
cans. That's not the one we made. That's the one you would get if you went online. Yep.
Yeah. Yep. So some sheet like that. This all starts with a sheet like that.
Right. For us, though, it's on
and
a
then
computer,
you
right?
do
So that
your
we don't have to scan it in.
right. Yeah. Right. So and then you aggregate this across individuals to start doing these more complex analyses. Do you look at it across time? You know, do you look for
Yes,
trends
absolutely.
across
That's the
time?
outcomes piece of
And
that.
then
Yes.
and then have you ever thought about trying to integrate community triggers into that? So let's say a big plant closes down and the unemployment rate goes way up. Does anything, have you tried to do any of these external things that may influence some of these outcomes and relate that to what's going on in the individuals?
No, but that is an excellent idea. That we're not at that level at all. But those kinds of larger, within the ecological model, that would make perfect sense. And that's going to, of course, also those kinds of changes are going to also increase, of course, the amount of people who have Medicaid in an area, and are going to shift even provider access issues. So those would be very important. But as of yet, no. Now, stuff like that does get brought to the roundtable. So we'll move into a county
Yeah.
where someone says, well, in that county, such and such is going on. The big thing was that we have this shale digging people, oil miners, and so there's been these shanty towns is too strong of a way of putting it, but mill towns, or I don't know, a town has popped up, populated with, yeah, exactly.
Man camps.
These will have, though, families in them too, but these are families that really need resources and services very quickly. And they will also be from different places, and and of course we're in rural areas, so new people are always difficult. So we get stuff like that brought to the roundtable, but not in a formal way.
Yeah, or there might be other environmental things. You might even look at seasonality. It could be that some of this stuff is more severe in the wintertime and less severe in the summer, or vice versa. So it might, and then you could sort of predict. Okay, people need to staff up more and a certain time of the year, and maybe encourage people to go on vacation a different time of the year. So it seems like you could integrate a lot of different data sources into the basic data that comes from that form that the providers fill out.
These are these larger structural issues, which are definitely helpful.
And Stefan has done some work on networks, and I'm wondering, Stefan, what do you think of, are there any network kinds of questions that come up on, with this kind of data? I mean, are you able to link from the form sort of family relationships?
I can see
And
Stefan
he's typing.
Yeah.
Other folks that want to type in a question too. Yeah. So yeah, he's kind of what's the neighborhood influence?
Yeah, I can say this appears right. So there are cans, I should say, that are out there, and in fact that are very popular. I'm trying to I want to think the Massachusetts cans has questions directly to, oh, and the Allegheny cans, I'm sorry, the one in Pittsburgh has questions, many questions directly related to the neighborhood. Um, and the Massachusetts cans, I believe, does as well. Peers is definitely measured in those kinds of cans, and that has not been the direction we've gone with this one. We've been very narrowly focused on things that are clearly medical because of the fact that I'm trying to make claims that are going to impact Medicaid distribution. And there's a lot of fighting in regards to is this a medical service or not? That's such a big issue. So we really designed a cans that we can confidently say is measuring things that are classically considered medical. But these kinds of things are obviously very important, and we've got research out there that shows that the neighborhood influences all sorts of metrics on mental health and functioning, as well as substance abuse. I know is one it's one I'm happy to be familiar with, is impacted that way. But our particular tool doesn't do that. But that doesn't mean that the data couldn't be integrated that way to learn more about that.
Thought you had some interesting comments about the differences between researchers and providers and how they approach this. Are there groups where you're finding that the practitioners are just not enthusiastic about this, and what are some of the reasons that they might have for not being enthusiastic?
Yeah, fortunately, thus far, I have not met that. I mean, I think I also might be in a honeymoon period with some of the providers I'm working with. The truth is that, so I've been very focused on clinical psychologists who are making these decisions, and that particular group of people has felt very beat up over the last 20 years that this profession has existed in Pennsylvania. And they have been very excited for something that's going to back them up, is how they see it. Now, as the algorithms become more rigorous, I'm wondering, am I going to have clinicians say, whoa, wait a second. I've always referred to such and such a service, and then such and such a service gives me a day a week, and I come in here and I bill my 5 evals and I make my money. But now I'm coming in using your tool, and I'm recommending evidence-based treatments for this kid, outpatient for that kid. Things are all over the place, and the provider that I'm working with doing these evals for, they don't want me to come in anymore. They'd rather have someone not using this tool who continues to see their program as the right answer. And so that is a concern I have moving forward.
Yeah, I suppose too, if a particular group isn't shown to be effective in this, that there might be two different reactions to that. One is to adjust their services. The other is to stop participating.
Right. Exactly. I mean, and that's the politics side of this thing, and that is going to happen. There is, especially with this BHRS, the sort of traditional wraparound. I mean, there's a general consensus that it's overused, and I think that general consensus is right. And we did a pilot on. We've already got data on this that goes back several years now, and this matches what I've seen other groups doing this kind of stuff have found, is that those services have an impact right off the bat, and then there's just this long-term linger, and then things very often on certain profiles can actually start to get worse. And of course, when things get worse, what's the answer? Do more of the same, right? And so our data is not going to do that. When our data shows that things are getting worse, we're going to probably argue it's because this client's not matched well to the service. This was probably not an appropriate length of time for the service. The evidence is going to make a recommendation the other direction. And at that point, this is going to be politics.
Yeah. Well, I'm not seeing any other questions coming in. I want to thank you for a really interesting and stimulating presentation. I think will help us think about our project as we move forward, and we'll definitely want to keep track of how yours is going and touch base again in a few months to see what you've learned in the
Yeah,
meantime.
great. And please, there's my email address here. I think I can move it. Here's my email address right here. Please reach out to me. And as you can see, we are very focused on practical issues with our data. But as it comes in and as we generate it, we're more than happy to share it with academics who have a legitimate research interest in it. It's just that's not what we do. Okay.
Excellent.
Thank
Well,
you.
thanks a lot.